Thanks, Morad. I appreciate to be here, and thanks for the invitation. I hope you guys are doing well. So today I'm going to talk. This is one of the recent work that we have been doing about using, biosignals like speech and other modalities. I'll talk about expand that later to try to assess and detect, some neurological diseases or some emotion mood disorder for other adults, which is related to aging. And when we use biomarkers, more like, to find patterns that can detect or assess some particular disease. So first of all, I would like to thank my team. As a social, nobody can work by himself, or herself. So here I have a lot of amazing students that have been working in my lab, and scientists like Loriano, Jesus, and Thomas. So this is quite an old picture. So we have a lot of people that join. And all right. So yes, and we have an amazing collaborators, like doctors. They are from the field of geriatrician, neurology, and critical care and psychology. So this work today is a collaboration with all of them. So I'd like to I'll acknowledge that. So so the topic today is literally so so the topic today is about, as I say, about aging, and in all of the Western societies, and other countries as well, the older number of older adults over 65 is increasing, and it's hit the most highest number in the history. And by increasing this number of older adults, it increases a lot of chronic disease, and have some social and economical burden in the society and economy. So there's a lot of need actually lately to develop technology that can based on, digital or, for health to help those older adults live longer or simplify their life or actually help diagnosis to do a preventive, therapies and stuff like that. So that's what the research is about. So let me start here. So the aging in general, it can be described by three aspects. Okay, the functional, which is your motor system, the muscles and your motor system, the movement system. And for our research, when we talk about functional, when they say I want to assess or monitor the detect the function of the canal, we sometimes refer to what's called Parkinson's syndrome. So Parkinson's syndrome affects your motor system and make it more rigid, you have less coordination, and then I can manifest in the speech and other modalities that I will describe to what we're doing lately in this type of work. And also the second aspect is cognition, which is the memory. So when you get older, you tend to, you have to go through a cognitive decline. And for that aspect, for the disease we try to assess or we try to detect, we work in Alzheimer. And the third aspect, which is like a behavioral, and which with that aspect we work in emotion, depression, and try to do fight social isolation and loneliness. So that's what we try to do. So the outline of this talk is, first of all, we'll do a speech-based, because I know this is a speech and language conference. Then, and we will try to use speech and human language technology to detect and assess Parkinson, Alzheimer, and also some emotion depression. And after that, I open up saying like, okay, speech and all this Parkinson, Alzheimer are neurodegenerative diseases. So they have some relation to the brain. So the speech is only in one circuit in the brain, because by engineering we see that the one circuit in the brain. So it's not enough. So it's not everybody that has Alzheimer's or Parkinson will have a speech impairment, but it can develop other impairment that that by only focusing on speech we cannot detect. And that we will go show that our last work, which is using a multimodal, and I will show some recent work and result about that. So let's start with Parkinson and motor functional system, and how to use speech for that. So Parkinson, as I said earlier, is a neurodegenerative disease, and it's caused by the loss of dopamine, and which make the system, more, affect your motor system, movement disorder. It's a movement disorder. It affects your system. It makes it more slower, more rigid, more painful when the movement, and it also can affect your speech. Okay, and those are the four aspects of the motor system impairment that you can affect here, described in this picture, in this slide. So Parkinson affect about 1 to 3% of the population over 65. And the problem with Parkinson, there is no really a blood test, and you say take it, or you do something and you say, oh, you have Parkinson or not. And it's actually a clinical test. Okay, so neurologists usually take up to 3 years to have some kind of, not a gold standard, but final, like some decision about you have Parkinson or not. So the only way you can definitely have a final and like a diagnosis is that when you at the death, when you do the autopsy. It's the only way we know that this person has Parkinson or something else that is mimicking Parkinson syndrome. So there is a lot of needs, and neurologists and all physicians are in desperate need to have some new tools that can be digital. That's what we're trying to do here, to help them make a better assessment and diagnosis about Parkinson early on, because they can manage a better treatment. So the outcome, if you start the medication earlier, the outcome later on, it will be much, much better. And that's what we're trying to do with this work. So what is the problem with Parkinson? It's not just that Parkinson disease. There's a lot of also Parkinsonian syndrome, what we call Parkinsonian syndrome, that mimic Parkinsonian disease. For example, Friedreich ataxia, Huntington disease, PSP, MSA. So they are different than Parkinsonian disease, and they share some characteristics of behavior, the same thing as Parkinsonian. So here, what we're trying to do, literally, we're, from the first site in the, trying to differentiate between Parkinson and Parkinsonian syndromes in general, and to make sure that we can be able to differentiate and help the physician to do this better diagnosis and differentiation between the different diseases. So why speech? Why speech can be very useful to detect and assess Parkinson? Because as you know, as you can see in this MRI, the speech is very synchronized, and you need a lot of coordination of your vocal tract and position your vocal tract in certain way to produce a very quality of speech. Since Parkinson affect is so speech production is a movement system, it's a functional system, and also it has a cognitive aspect, because we try to produce speech, we process it in language, we produce a speech, and we also understand speech. So there's a cognitive also part of it, and also Parkinson has also some cognitive decline as well. But here, so speech can be a very good proxy to try to study if you have Parkinson or not, because the reason why Parkinson disease produces smoother, sometimes slower or less extensive articulation because of the rigid system in producing speech. So if you have a Parkinson and you have a tremor, so if we record you saying certain vowels like we can detect tremor from that. Okay, tremor is like the vibration that, for example, you have tremor in your hand. Sometimes you can also detect it in your voice. If you read sentence, like exact sentence for everybody, we can find a problem in perturbation articulations. Okay, if you use spontaneous speech, you're talking to people or normal people, or a physician in the room, and we record you, we can also get information about the prosody, the emotion, and even the cognitive, because that's what I said. Parkinson also has some cognitive aspect to it that we are not addressing here. We try to address Parkinson as a movement disorder problem, which means related to a functional system. So speech aspect, can have four aspects that we can use to try to detect Parkinson in each aspect, and each aspect we can extract features that can describe those different aspects. We have phonatory, we have articulatory, we have prosody, and we have cognitive linguistics. Okay, let's say. So we have the four aspects. For each aspect, we can extract some features that can allow us to do a better assessment and diagnosis about Parkinsonian syndromes. Okay. Here an example. I'll show you that, for example, that we use articulative, features, and we will show you a kind of visualization of the spectrogram, showing you what actually happened when you have a person like here for female. This is a normal female patient. Sorry, a healthy control, which is a normal older adult at 60 years old, and she's doing the test. So there's several tests the physician asks people with Parkinsonian to test, to say, for example, the pataka test. So we say pataka, 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 and you can see that pataka, there's a closer here. I don't know if you can see the mouth. There's a closer before the burst, okay, and you can hear it here. I don't know if you can hear it. I'm not sure.
Pataka, 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 pataka.
Can you hear the voice, audio?
Yes.
Okay. So you can see the pataka, pataka. This is the normal healthy control. Now, if we have a Parkinsonian syndrome, so as I say, you can see the closer, for the stop and the burst. if you take a Parkinsonian patient, the same age, and you can see pataka. For example, here you can see, for example, in this one, the closer disappeared. For example, here, this one here, the closer disappeared. For example, here too, the closer disappeared before the burst. So the sound changed from pataka, 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 it became badaga, badaga, badaga. So perceptually, it's hard to hear. But if you go for analysis in acoustic and everything, you can, even in the spectrochem, you can see that the closer is actually disappeared. And also this technology can be also used, for example, to help rehab. So when you have Parkinson and you see the speech pathologist, so sometimes we can help the pathologist say, okay, this person has a problem closing his or her lips. So the stops are not very well produced. You can work with this patient to improve that. So we can give specific ways to help to improve speech pathologists to help the patient improve their speech production. Okay, so let's do some example how we do some in terms of result and everything, and we go from what we've done in the past, and I'll tell you what we're doing now with the multimodal. So here we're working in the publicly available database. We have two Spanish ones, GTAs from Colombian and Neuro Voices from Spanish. This number of speakers about 50 for the Spanish one, and we have also the Czech one. We also have the Germany and the Italian one, but here I'm showing only the Czech, and the two Spanish. And as I say, you have sustained vowel, like when they say ah, and usually, for example, Parkinsonian people, we can detect tremor, and also they go to fatigue very quickly. That's one sign of Parkinsonian. We have the Baraka test, the Baraka test. We have the 6 sentence, and we have the monologue when you talk. So for each of them have this different speech that have been recorded, doing some different tasks, and we use that to detect, Parkinson or healthy control. So for example, here we take the audio, and we take some II. It's actually a ResNet system, get some embedding, and we do some classification, and it will take the Parkinson or healthy control. If you take II as a black box, I don't want to go into details, but we will be able to go more in the picture in a few minutes. You can achieve about 90% accuracy when you have read text, when you ask you to read the sentence, which is a fixed text, and we have a 0.94 area under the curve. If we take the speech from the Padaka test, we achieve about 80% accuracy, and with a 0.86 area under the curve. And here, the higher the better. Okay. So this is when we do, literally like take the audio, give it to an AI system, she's in a neural network, and you can predict Parkinson over healthy control. So another hand say, like we say, okay, we are, speech, scientists. Let's see actually which are the part of the speech are the most, useful, to detect Parkinson. So for example, as you know, there's a contrary aspect, the point of articulation. And so we split the speech in different phoneme categories. For example, fricative, liquid, nasal, plosive. And for each classifier, we build it in all these different categories, okay? And we started to do detection in the 3 different languages, like 3 different databases, the GTA, Neurophos, Spanish, and the Czech database. And you can see here, for example, FT means fixed text, the DDDK is the Praka test, the monologue, and the cross database is one we train in 2 and test another one. We want to see the general ability. We test on 2, so here we train in NeuroVoice, and Czech we test in GTA. So we see how they cross-generalize between the different languages and different databases collections. And you can see, for example, overall, Plosy gives you the best performance over the 3, on average over the 3 databases. The Plosy were the most helpful. We can also see that fricatives and voil are very good, better in terms of cross database. They generalize better when you go to a different language and cross it to different database. And we also find out that fixed text is actually the best for this kind of cases. Is the best to get used for your for detection of Parkinson versus healthy control. So this is, as I said, this is our previous work that we have been doing. This is an interesting thing. So we went from using II, given audio, trying to let the system figure out how to classify Parkinson versus healthy control. Say, okay, how about we segment the speech in different categories, and we use different categories to say which are the best to do Parkinson and healthy control. And sometimes physicians, they don't care that much about they have Parkinson or not, but they know why they have Parkinson. So what are the different features that show you that these features that can be a very good sign of detecting or Parkinson versus healthy control? Okay, and here we use NeuroVoice, German JITA, and also Italian and German database. And here we can say, for example, F0, which is a prosody kind of features like a pitch standard deviation. And you can see that in some database it helps differentiate between control and Parkinson's disease. For example, here, silent duration. So Parkinson's disease tend to take more pauses than healthy control in their different tasks. So, and also word count. So we use automatic speech recognition to transcribe, and we find the word counts. And you can see that Parkinson's disease tend to use less words compared, but when you use a monologue, when you have an open, spontaneous conversation, they use less word counts compared to healthy control. So we call this interpretable features. So physician really, because all this, for example, for Parkinson, all this Parkinsonian mimic, I will talk about it later, we really want to see what are different features that are specific to different disease that we can use that later, that are easily interpretable, that the physician can use them later in the future for detecting Parkinson's disease. Okay? So this is, for use, as I said, an overview, quick overview, sorry, it's going very fast, a good overview about how we can use speech as biomarkers to detect Parkinson's disease versus health control. So now let's use Alzheimer. Let's talk about Alzheimer's. Alzheimer is also another degenerative disease that causes brain atrophy. And here, for example, here you can see healthy brain versus Alzheimer brain, severe Alzheimer brain. So Alzheimer affects more population over 65 than Parkinson. So Parkinson was 1 to 3%. Here it was over 10%, 11.3% population over 65. And there is a huge need of early detection for Alzheimer, and there's a lot of money from US Health, NIH, National Institute of Health, because there is some drug that's shown that they can slow the progression and sometimes even stop it. There's some good sign for it. So the physician and the people here in the US are trying to really use technology to help them do an early assessment and diagnosis of Alzheimer so they can start the treatment early on. And that's why this work is coming through. So in these things we use, so we try to use speech, to detect Alzheimer disease. And for this work, we use public database that it was an evaluation campaign, and the references here from the database called the Dimension Bank. And in this Dimension Bank, people were corrected. We have 78 patients and 78 healthy control, and they were collected, described in this cognitive picture. Okay, this cognitive picture. And also, so we get the recording describing these pictures. And also, it was provided with minimum mental status score evaluation. So this is an score evaluation that the physician used to see to assess the severity of the disease, and the score range from 1 to 30. Okay, so MMSE, minimal status evaluation score, indicates the severity of the disease, and it's go from 1 to 30. So in this case, during this evaluation that we did, is we try to detect a Parkinson, you have Parkinson or not, and also predict the severity, which is the MMSE score. So here we try to build a system that is based on just acoustic, and we use some ResNet to do some embedding, then we do some classification, and we detect Alzheimer and also the severity of MMSE score prediction. So we have classification and regression. We also said, okay, you get some statistic about the acoustics, because we believe that Alzheimer, they have a more memory, like a cognitive decline, so there is memory, so they take time, take more pauses to take their thought before they speak. So we thought that adding in some statistic about the pauses and the silence can be a good thing. So that's why we said we do voice activity detection, detect the silence, take the pauses, and use that as statistics for that Levian and standard deviation and everything. We give it this classifier and to do Alzheimer detection and also severity. Then also, because it's a memory, we said we need some linguistic information, some linguistic models. And So we take the speech recognition, we transcribe it because they are transcribing a picture. So okay, so it's it's like a monologue kind of thing. So then we get the text, we transcribe it, we do an embedding for word embeddings for it, we do some representation for it, and we build a classifier to detect Alzheimer's and severity. And so for each system, we can see the result. We can also combine them, combine the embeddings and do a fusion to combine a classifier to combine all this source of information to detect Alzheimer and also MSC score. And so here as I say, we use the acoustic, the silence statistics, as well as the transcripts. And here you can see the result. If you're going to use acoustic, we achieve an accuracy of 73% with an error for prediction error is 6.24 for MMSC score. If you take the transcript, you got the better detection, only the text, as I say. So we know that linguistic and memory can be vocabulary related. So vocabulary means words, and we also use the silence features. It's as I say, it's a little bit better than chance because the chance is 50%. So it did not show too much improvement in terms of accuracy detection, but it has about 80%, 8.0.5 error prediction. If we combine acoustic plus silence, we went from 73 to 70.75, so we have some good improvement. If we do acoustic per transcript, we went from 70.8 to 79, 0.2. And if we combine the three, we went to 81.48. So even the feature silence was almost random, to be honest. But when we combine it with everything else, it actually gives us a really nice boost, and we actually have the best result when we combine that. It's a little bit negligible in terms of the prediction of MSC, but it's still a little bit, it's actually negligible improvement, so it's the same. So this is, talking about Alzheimer's. So I can tell you, so you can see speech, used for functional behavior, like motor functional system, and assessing functional decline, using for the Parkinson detection. We can also use speech for cognitive assessment, for Alzheimer. We can also use it for behavioral, which is emotion and depression and stuff like that. So as you might be not familiar, but depression affects more than 90 million Americans every year. For example, here, depending on regardless of their age, gender, or race, and more than 2 million of the 34 million of older adults over 65 suffer from some kind of depression. And the reason why, if you go through chronic disease like Parkinson or Alzheimer or a heart attack or something, at some point you will suffer some depression, okay? Because it doesn't get very well and something like that. So there is a lot of money trying to help, detect the kind of depression to try to treat them. So the idea here is physician cannot always see patient. But imagine you have a system like your Amazon Alexa or Google's system or Siri waking up every day, 3 times a day, asking how do you feel, and having a conversation with you. So the system can assess how is your emotion, how is your mood today, and if you are down for a few days, you flag a system, the doctor, the physician, and the physician can call you for intervention. This kind of thing that we want to do. So here we wanted to do like you get a speech segment, and you want to detect which kind of emotion or what is your emotional status at that time when you produce a speech. As I say, can be useful for physician because physician cannot see you every day. The doctor cannot see you every day, to be honest. But machine can talk to you or something and then report the assessment saying like, okay, this patient has been down for 4 or 5 days, maybe it's time for an intervention, something like that. So this is exactly what I'm trying to say here. We suggest an assistant who created a long time ago, trying to monitor your emotion and mood. And if you are down you have a negative emotion for 2, 3, or 4 days, we can call you for intervention. So as also similar to Parkinson and Alzheimer, there's also public available database that you can use speech to do emotion assessment. Of course, majority of them are act speech. For example, IMOCAP is acted speech, no constraint on the speech content, it's fluid, Kimadi as well is acted speech, it's a fixed sentence. We have full sentences that actors use different speech to record them, emotion speech to record them. And, but however, the one thing that's more natural, which is MSP called podcast, which is coming from the University of Texas, Dallas, from Professor Carlos Busso, and it's coming from podcast, the constraint in the what has been spoken, but this is more natural and more realistic. It's not like active speech. And you can see that if you see the F score, the F score is higher the better. When it's acted, the system tends to do very well, but when it's real, when it's more real, it's very hard. So we're still working to improve it. So emotion is a little bit tricky because it's not like black and white. It's like literally like there's too much gray. That people that even when human are not very good in allocating emotions. So what we do is literally have a segment with 5 or 6 people listen to it, and we do a majority vote. So and the kappa, the agreement is also low because of that. So that's the reason why emotion is always a little bit tricky in this. So this is, as I say, in terms of aging, so we cover the 3 aspects, and we're interested in the functional and cognitive and the behavior as well. So now, as human body is not just speech, okay? So it's a complex system. So when I started this work, I was working with neurologists, and neurologists tell you, oh, everything is in the brain. And if you talk to the heart surgeon or cardiologist, they tell you it's the heart. But if you work with geriatrician, they say, Najim, I see the whole picture. Geriatrician, when they deal with older adults, they see the whole assessment of the whole body. And that's why I say the whole body is a complex system. It's not just a speech production And for this reason, we say, okay, well, let's step back. Let's do, a better assessment about the different aspects of your body. And we started by speech, which we already had. We added eye movement, and we added handwriting. And so eye movement is also a circuit in the brain. Okay, handwriting is also a circuit in the brain. And handwriting gives you the coordination as well, and the tremor, if you're looking for Parkinson, and eye movement is the fixation, how much confused you are. So we can see that some of the features are that we find out that are very interesting. And so we started by the tree, and we added another one. At the end I will talk about it, which is gaits, the walk. We have a similar sensor or a pad, and we see how you walk. Okay, and that one is just has been included maybe less than a year ago. So as you know, we can have a patient, or participant, have the control. We can record that speech with a microphone. We can use an eye tracker, extraocular movement recorder, and we can use handwriting. We can have a pen and a pad, like similar to an iPad, but it's more like a pad that can also measure the pressure. Okay. To capture your handwriting. So this is a database we're creating at Hopkins here. It's under constructions. So the number keeps increasing very quickly. It has changed since this number here, how many patients we have and how many control we have. That's been dramatically increasing very quickly. And this is something we're recording at Hopkins, at the hospital, in different hospitals, using Memory Clinic, Alzheimer's Treatment Center, asthma center for geriatric, and the main Hopkins, Johns Hopkins Hospital. So, and also you can see we have control, we have Parkinsonian disease, we have Alzheimer, we also have Parkinsonian mimics. Remember when I talked about that Parkinsonian syndrome have different Parkinsonian mimics. So like ataxia, Huntington's disease, MSA, PSP. So those, they mimic, but they are very hard to differentiate between Parkinson's disease. So when the neurologist see a patient, they don't know how this patient will involve. Is it going to involve in Parkinsonian or is it going to be an ataxia? And for each one, we want to define different biomarkers or different biosignals that can help differentiate or cluster the different groups. So going forward, we can the physician have the better assessment about the diseases. And you can see here the different age, distribution of the data, and we are trying to improve it. This is also, you can see male versus female. We're trying to balance it, to be honest. So we're trying to do, we're not really doing a good job for Alzheimer. We're trying to work to do better for that. So it's more like a male-dominated data for that category. So, okay, so now let's say we have speech, eye movement, and handwriting. So for speech, we use microphone to record it. So we ask people to do reading, object and action and naming, picture description like cognitive, syllable repetition, some solving. And you will see, I will show you an example later one thing that we are also doing, we're trying to record as people is a different, record the different biosignals, handwriting, speech, and eye movement synchronizing in the same task. You know, I will show you in a video later that you can see that we can record them in synchronizing in the same task. And the reason why, because if you are telling, for example, a patient that I'm going to record your voice, you literally see the patient stand up and making sure that he's going to produce you the best speech he can do, because he wants to compensate for the impairment that the patient has. So we call it compensation effect. So if you ask him to do multitask, he loses that compensation effect, and that's the reason why we believe in that. So in the result I'm going to show just now, using speech only, we use a cookie test picture description, you know, speech recording, and we also use a strip test. Strip test is when you would ask you to say the word and not the color. For example, here you say yellow, or you say, or for example, you say blue, or so you can say the color, not the word. For example, blue, green. So sorry. So that's what we call strip test. So it's a way to confuse your brain to make it work better. That's also to test how it works better. Sorry, that's what I'm saying. And here is an example. So we tested this to the speech and the system to detect interpretable features, so features that we can interpret. I will describe them in a few minutes. We have a lot of them, but I selected the one that have promising results, the differentiate between different category of disease we have, disease we have. Sorry. Here, for example, here there's the strip test in the top and the cookie tip in the bottom. So we configured three complementary sets, okay, of features related to cognition, speech, and language. And we conducted, you know, statistical analysis to examine which feature differ between normal diseases and control, healthy control. So as you can see in the first four, you know, let me check if I can. Yes, the fourth boxes, the first box starting from the left, okay, top left. Results suggest that during the strip test, subjects that with AD took longer, higher amount of speech time, to be honest, to complete the task, and they had greater reaction time compared to Parkinson and the other one. Okay. In the cookie tip, Alzheimer's disease subjects use a significantly lower number of known phrases compared to control, for example. For example, on the other hand, PD, for example, Parkinson's disease, show a significantly lower ability to modulate the pitch because of tremor, okay, in the discord compared to control. So those are really interpretable features. We want to look for them, for those features, and we test them using statistical analysis, how they are good in detecting or not detecting or predicting a disease, Parkinsonian, Alzheimer, or Parkinsonian mimic, okay? So we are interested in separating all the different neural diseases, like Parkinsonian, Alzheimer, and Parkinsonian mimic, okay? So this is speech. So we also collect eye movement, and for eye movement, you can see the device here. That's actually literally the device what we have, and we can use fixation, saccade, anti-saccade. You know, that's fixation is like when you fix things. Saccade is when I ask you to look this. Anti-saccade, if you click here, you have to look the other way. Fix your head, you look the other way. Memory pursuit. So I will ask you to follow this. You know, go up and down. You know, a visual exploration. You know, for the things. And here, for example, where the system, you know, the green line is where you're supposed to look, and the purple where the participant is looking. You can see that, and this is a difference. So we can see that the blue thing is a difference in the gaze. So here we can. So when we use the system, we can determine. We can find where when the subject look at each word, okay. In the strip test, for example, here's a strip test, you know, example, and calculate the metric about the gaze, okay. For example, we can see the difference and the number of times the subject have to look to the words, and we found out, for example, Alzheimer, when they start reading, for example, when reading, Alzheimer comes back often to the word because we know where they're fixing, so they come back to the word. So because I'm not sure what to say, so the memory is not clicking immediately. So Alzheimer will look at the word much more often than control and other diseases like Parkinson and Parkinsonian. Okay. We can also analyze, for example, when you fix a point, we can analyze your metric, how much it vibrates. And we find out, for example, you can see that, when you're fixing the word Parkinson's, so when you're fixing the word, for example, because we know where the word is and where they're fixing it, Parkinson's subject have much more variability in the location. The vibration, the eyes, like it can be similar to tremor in the location in the gaze compared to Alzheimer's and other disease. So Alzheimer tend to come back to the word often. Parkinson's disease move, the fixation is not stable. They move a lot. So sorry, I'm hoping I'm still in time. So also we have handwriting, and and we use a pad, which is literally this one here in the top. This is the pad we have, and you can see the task here, and we have we collect the trajectory, the points. We also in the air and in down, okay, and the pressure. So all this can captured by the pen, and we have several tasks: copy image, copy cube, copy text, and handwriting can be a very good assessment of cognitive function because we ask you to write something or something, and also motor because it's using your hand and muscles and everything. So it needs a lot of fine coordination. Here, for example of Parkinson handwritings. Parkinson handwriting. Control and Friedreich ataxia. For example, Friedreich ataxia, they have tremor more. You can see that. And here we can also see, for example, if you look, for example, IoT is amount of data, and you can see that Alzheimer people take more points to finish the, for example, drawing a text or drawing a box or something like that. Okay, so they take more points compared to Parkinson or Parkinson because they're not sure about themselves, so they make sure that they get it right. And they also take more time. Alzheimer people here, you see that they take more time to accomplish the task. So this is really a very good biomarker to how to differentiate Alzheimer from the rest of the things. And you see that we can use the pressure and how they differentiate between everything. But you can see the picture now. Now this is our more statistical analysis about the different interpretable features to differentiate between Alzheimer, Parkinsonian syndrome, and control. So here now, what we did here, we say, okay, so we have all these tasks, okay, for the handwriting and movement speech. Okay, for all these tasks, we can extract some features, handwriting and everything, such as how the number of features we can extract. And we can build classifier on top of that to predict accuracy. Parkinsonian, handwriting, this is Alzheimer versus control, okay? This is Alzheimer control. If we use handwriting, you get up to 73%, the best for handwriting or different tasks, because there's different tasks. Eye movement, you can get also 70% using anti-saccade vertical. For speech, we can achieve 78 using stroke color. And if we take all this, all these features and do fusion, we can achieve 84%. So the best one was 78. We can go to 84% by fusioning things. So there is some complementary. So here we're not fusing it at the synchronized level. We're fusing it at getting the feature for each modality, then combine it, fusion it, score fusion, and you will get this. Okay, so that is definitely complementary. That's what's our first assumption and hypothesis, that this not all people will develop speech impairment, but some people will, but some people we can capture the eye movement behavior. We can capture handwriting behavior, and that's what we're trying to do. Here, an example of what we're trying to collect when it's synchronized, and we're still working how to make this fusion, actually the system, we use the 3 modality when it's synchronized, because this is the most important part. Here we go.
3 plus 1 is 4. 4 plus 3 is 7.
The green line is when the pen is up, by the way. The green and the black written is when the pen is down.
6 plus 7 is 13.
So you can see that we have speech, handwriting, and eye movement, and speech, handwriting, and eye movement in the same task synchronized. And we are working on how we can make the system really use them in a synchronized way. Recently, we are modeling more biosignals, which is using gait analysis. You can see this is my colleague Encore. He's a neurologist. You can see those captures, the orange captures are the captures, and this is a pad. It models also the pressure when you walk on that pad. So we have that. So we are collecting the gaits, your postures, how you walk, the pressure you put in it, and you can see that, and for that we are collecting for PD because, we'll probably do Alzheimer because people say Alzheimer also tend to develop some gait issues. Okay, and we also do frail. Frail is a syndrome that it's when you get old. You don't have any chronic disease, but you're just old. It's frail. That's why we call it frail. So, and they usually have some gait issues as well. So we're collecting a lot of, we already collected 60 participants. The pad, that we use is 16 foot on it, and you can see detect how much the pressure and how long, how much step they do, how long the step is, how long it takes them to accomplish a task and stuff like that. And you can see the different signals we get from there, and also the signals in your body that show you like what is your postures when you're walking. So all that will be captured in the system. So as a conclusion, I know that I went a little bit too fast. Sorry for that. So as a conclusion, speech biosignals. Speech can be biosignals or speech can be used to assess neurological disorders like Alzheimer's and Parkinson. It can be also used to detect depression and mental health status. Here, guys, you understand, people with Alzheimer's and Parkinson also develop depression. We are not doing that. We're not assessing depression in neurodegenerative diseases. So we are working on it. We will try to do that because they say if this behavior is happening, it's because of the disease or because the patient is just depressed. So that's why we want to answer that question. We're also proposing new data sets. We are hoping to make it public soon when we hit a good number of participants. So the result can be statistically meaningful using multimodal synchronized biosignals. We find out that multiple signals can contain complementary information based on our initial result. And the reason why we are going multimodal, as I told you, because we want speech is one circuit in the brain, because we're engineers, we see as circuits. So handwriting is another circuit. So, and if you don't, and eye movement is another circuit, gait another circuit. So if you use all the different circuits as a proxy to understand what's going on in your brain, you have a better assessment of what's going on in the brain, and you have a better assessment of the neurological disorder or movement disorder that we can try to detect or assess. And also multitask help people to not mask and compensate, for their motor impairment. And that's it. Thank you. Sorry if I was too fast because I thought I had 40 minutes. That's why I tried to go a little bit fast. Okay. Thanks, Murad. I appreciate to be here, and thanks for the invitation. I hope you guys are doing well. So today I'm going to talk. This is one of the recent work that we have been doing about using, biosignals like speech and other modalities. I'll talk about expand that later to try to assess and detect, some neurological diseases or some emotion mood disorder for other adults, which is related to aging. And when we use biomarkers, more like, to find patterns that can detect or assess some disease, particular disease. So first of all, I would like to thank my team. As I saw, nobody can work by himself, or herself. So here I have a lot of amazing students that have been working in my lab, and scientists like Oriana, Jesus, and Thomas. So this is quite an old picture. So we have a lot of people that joined, and some people graduated and left the group.